Hey everyone, my name is Dr. Jared Bonaquisti. I am a physical therapist with Kinetic Physical Therapy, and today we're going to be talking about rotator cuff injuries, focusing on tears. If you've been following this sequence of presentations, last week we talked about tendinitis of the rotator cuff, and today we're focusing on specifically rotator cuff tears. So, looking at the bony anatomy of the shoulder, we're going to start with the acromioclavicular joint, which is a combination of the clavicle on the front of the shoulder and then the acromion bone, which is right here, which kind of protects the superior or the top of the shoulder. That's connected to the spine of the scapula, which again runs right into the scapula itself. The next joint we want to look at is the glenohumeral joint, which is a combination of the humerus, the head of the humerus here, which sits in the glenoid fossa, which is a smooth kind of concave surface, which allows for any motion of the shoulder that can be performed. And the last bone we really want to focus on is the scapula itself, which is where those rotator cuff muscles are going to attach onto, and that's where that activation is going to be generated from to create internal external rotation or that dynamic stability. So looking at the musculoskeletal system of the shoulder, we want to focus on the rotator cuff muscles here. So if we're looking at this shoulder, this is the anterior or front of the shoulder. So if you're looking at a person, this is their right shoulder. The big broad muscle underneath is called the subscapularis, and that attaches to the medial aspect of the scapula, runs underneath the bicep muscles here, and then attaches onto the anterior and lateral aspect of the head of the humerus. And this is where you're going to get that internal rotation, right, or moving your hand towards your stomach, and that stability created from the anterior side. If we're looking at the posterior aspect of the shoulder, again, this is the same right shoulder, but now you're just looking at that person from behind. You're going to see the rest of the rotator cuff muscles, which are these three right here. You're going to start with the supraspinatus, which is going to attach to the superior and medial border. It's going to run underneath that acromion bone and the AC joint itself, and it's going to attach onto the superior, posterior, and lateral aspect of the head of the humerus. You have the infraspinatus muscle, which attaches onto the medial border and runs all the way down close to the inferior angle of the scapula. It runs all the way to the posterior and lateral aspect of the head of the humerus. And then you have the teres minor, which runs from the lateral border and then to the posterior aspect and lateral aspect of the humerus. Here is where you're going to find external rotation as those muscles contract, and then also that posterior stability of the rotator cuff. So the purpose of the rotator cuff is designed to create stability to the glenohumeral joint by reactively turning on when needed. It could occur in an open kinetic chain or in a closed kinetic chain movement. So when we talk about reactively, this means that when you're catching a ball, or when you're throwing a ball, or when you're picking something up off the ground, laundry basket, weights, you don't think to yourself, all right, I'm going to turn my rotator cuff muscles on here. No, it just happens. And that is how we want to train these muscles when we get to our physical therapy and when we get to our training. But going back into the purpose of it, knowing that it's reactive, this means that it happens when we're not thinking about it. So looking at an open kinetic chain movement, that's when you're lifting a cup up off the table, right? Your arm is moving, same as it would in a closed kinetic chain, but the force, that external force, is going to be away from your body there. In a closed kinetic chain movement, if you think of doing a push-up where your hands are on the ground or on a bench, something immovable, where your hands are going to be stationary, and you're going to be pushing yourself away from the object. The rotator cuff also creates internal external rotation, like we talked about in the last slide, where those muscles are attached to. And then lastly, the rotator cuff sits the head of the humerus into the glenoid fossa at rest or with any of those activities. So they reactively turn on to make sure that the humerus stays in that glenoid fossa so that you can have the appropriate motion needed, right, and the appropriate surface contact to allow you to get that full range of motion that you need without any irritation to the tendons, any injuries with the labrum. So what is a rotator cuff tear? When we're looking at a tear, it's designed, it has been defined as the end result of tendinitis and tendon degeneration, and is often a tear in a portion of the rotator cuff. So they can be classified as traumatic versus degenerative, acute versus chronic, and partial versus full thickness. Traumatic meaning you fall on your shoulder and you tear the muscle that way. Degenerative meaning over a long period of time. Acute being less than 3 to 5 days, and chronic being greater than 3 months. Partial and full thickness is how we see it in the clinic most often. It's the easiest kind of to be able to describe. Partial meaning anywhere from, 1% up to 99, and then a full thickness being that full 100% tear where that muscle belly, there are no muscle fibers attached. Acute tears, right, being less than 3 days, less than a week, are rare and only 5 to 8% of cases seen. And that study was done in 2016. Most cases we're going to see partial or full thickness, and they're going to be chronic, so greater than 3 months. Which brings us to a question of, well, if I've had this for more than 3 months, why did I just start feeling pain in the last 3 days there? And that's something we're going to talk about in a little bit. So common presentation, symptom-wise, you're going to have pain at rest or activity. Could be local to one specific area or radiating into the lateral arm. Pain with shoulder flexion, right, so we're lifting right up in front of you, or abduction going out to the side. Difficulty sleeping on that side or on your back, and noted as dull achy pain that gets worse in the afternoon. Some of the signs that you may see, it may be difficulty with lifting. You may have muscle weakness. You may have the inability to raise your arm at all. Those are some of your more significant type of tears that you can have. Or it could just be something as simple as decreased functional mobility there. So you're having pain, you're not able to get the range of motion that you want because of those weakness and because of the pain there. So diagnosing and, what's the diagnosis, what's the prognosis here? Or how do we diagnose and what's the prognosis? So diagnosis, looking at the usual way that we would look at this. First of all, our doctor's probably going to recommend taking an x-ray, which is going to be inconclusive, usually due to this being a soft tissue injury rather than a bone injury. X-rays look at bones, right? That's how you get your image. Some doctors can make an estimation due to possible swelling seen in shades of gray on an x-ray or where that swelling is. An MRI is going to show a lack of continuity in the affected rotator cuff, so this is a possible way that it can be diagnosed. Or you can use an arthrogram, which is most consistent and reliable way to diagnose a rotator cuff tear. That means that they're going to inject a dye into that area, and when they see the dye start to leak out, when you see that lack of continuity, that's going to be your sign that you have that tear. And from there, they can give a certain range of what they think it's, what percent of partial tear, or are we going towards a full thickness tear. Physical therapists are going to be able to use special tests along with your history, along with the mechanism of injury, to give that diagnosis of a possible tear. So prognosis, right? We think of a tear, we think, oh, it's got to be repaired. Well, not always. Prognosis for recovery without surgery is very good. One study done in 2017 noted that surgery was not more effective than conservative treatment of rotator cuff tears. Another study found in a group of 53 patients with full thickness rotator cuff tears, that meaning none of the muscle fibers are attached anymore, 74% of them had no or slight pain following conservative care, right? And they had a follow-up time of an average of about 7.6 years. So that means that most of these people are functioning at a high level or at their level of activity of daily living without having any pain or slight pain whatsoever, just with conservative That's not getting any sort of surgical intervention, which means that it's not always the case that just because there's a partial tear there, that you need to get that surgery repaired so that that muscle can function properly. We're seeing it right here in the research that you can still have an active lifestyle and you can still be very effective in your everyday using conservative treatment. So what does a surgical management look like? All right, so let's say that you end up going through with the surgery. Phase 1 of this surgical protocol, which was by South Shore Hospital Orthopedic, phase 1 is 0 to 6 weeks passive range of motion, meaning you can't lift your arm by yourself. No active reaching, and a sling at all times for 4 to 6 weeks. Phase 2, 6 to 12 weeks long of active range of motion. So if you're sitting in your chair right now or you're standing listening to this, just lift your arm up overhead. That's active range. No more resistance than that. Can't put dumbbells on it, can't lift anything heavy. So 12 weeks now and you haven't lifted anything with that arm. Phase 3 is 12 to 24 weeks, and this is your strengthening phase. So no heavy or repetitive overhead lifting or reaching. And then you're limited on what you can do to the gym, or what you can do in the gym, or even getting to the gym. That's late in phase 3. And then phase 4, 24 weeks to 1 year, return to sport or activity. Now, this is a conservative surgical protocol. Some can be a little bit more progressive, a little bit more intense, but this is the one that I've seen. This is the one that I've used in cases when I don't have any protocol given. Because even after surgery, you think, hey, everything's all fixed up. Not really. Your body still needs to heal, so it needs to take time. And if you rush back into that, you run the risk of a possible re-tear, and then going through this process either all over again, or using conservative management to try to treat that failed surgical intervention. So conservative management, what is that going to look like? In physical therapy, our whole goal, right, is to get you back to general or specific exercises, specific activities at home. And we're going to be doing that by looking at the deficits. Is it thoracic mobility? Is it scapular mobility? Is it rotator cuff strength? Is it functional mobility? Is there something, a firing pattern that's not going on there that's decreasing the ability to do these activities? That is what physical therapy is going to try to improve upon. Right, so progressive exercise plans to promote healing of that remaining tissue, like we talked about before. If it's surgical, we're going to take our time because we want that tissue to heal after surgery. If it's just a chronic rotator cuff, non-surgical, we still want those tissues to heal that are still attached there, and that can happen. And then focusing on restoring function so that you're back sooner than you would be if you did surgical intervention. Let's take an example of a tennis player here. Now let's go back. If you do surgery, you're not going back to your sport until 24 weeks at the earliest using this protocol. And you do conservative management, we're hoping to get you back anywhere in between phase 2 and phase 3 here, back to some activities. Not all, but maybe even some. And again, it could be earlier. Everyone's a little bit different. But just look at the difference there. You're cutting pretty much your time in half in getting back to the sport that you love if you try conservative management first. A surgical intervention can always be done. Conservative management is definitely the way to go early on. So if you need help or you have any questions, here is our contact information here, right? Our clinic phone number, my email address at the bottom here. We are looking to help out any way we can. That's why we do these sort of educational presentations. Or if you have a physical therapist that you know and you've gone to before and you're having these type of issues, please reach out, talk to them beforehand, and get a game plan together so that you can return to those activities. Please reach out also to any of our social media pages. This is going to be left up on YouTube and on our Facebook page, so you can always go back and follow us there. And if you have any questions, please feel free to email me or give us a phone call. I hope that this was educational for you, and I hope that you guys return for our next set of lectures, which is going to be focusing on labral injuries and other shoulder pathologies. Thanks.